Welcome to Uberschool's comprehensive guide to cardiovascular pathology for the USMLE Step 1. I'm Pete, and I'll be diving deep into this crucial topic with my colleague Crash.
That's right, Pete. I'm Crash, and we're here to break down the complexities of heart disease in a way that'll stick with you long after the exam. Let's get started with the cornerstone of cardiovascular pathology, atherosclerosis.
Excellent starting point, Crash. Atherosclerosis is the underlying cause of most cardiovascular diseases. It's a chronic inflammatory process affecting the arterial walls, characterized by the accumulation of lipids, inflammatory cells, and fibrous tissue.
That's right, Pete. The pathophysiology of atherosclerosis is a bit like a multi-act play. Act 1, endothelial injury. This can be caused by various factors like hypertension, smoking, or high levels of LDL cholesterol.
And once that endothelium is injured, we move to Act 2, lipid accumulation. LDL cholesterol sneaks into the arterial wall where it gets oxidized. This oxidized LDL is like a beacon for inflammatory cells.
Exactly, which brings us to Act 3, the inflammatory response. Monocytes from the bloodstream enter the arterial wall and transform into macrophages. These macrophages gobble up the oxidized LDL, becoming what we call foam cells.
Nice analogy, Crash. And don't forget, as this process continues, smooth muscle cells from the media of the artery migrate into the intima, proliferate, and produce extracellular matrix. This forms the fibrous cap of the atherosclerotic plaque.
Right, you are, Pete. Now, let's talk about risk factors. We can divide these into modifiable and non-modifiable factors. Can you give us some examples of modifiable risk factors?
Sure thing, Crash. Modifiable risk factors include hypertension, diabetes mellitus, smoking, obesity, physical inactivity, and dyslipidemia. These are factors that patients can control through lifestyle changes or medical interventions.
Excellent. And the non-modifiable risk factors?
Non-modifiable risk factors include age, risk increases with age, male gender, though the risk equalizes after menopause in women, and genetic factors. Family history of premature coronary artery disease is a significant risk factor.
Great breakdown, Pete. Now let's discuss some of the complications of atherosclerosis. One of the most feared is plaque rupture. When a plaque ruptures, it exposes the thrombogenic core to the bloodstream, potentially leading to rapid thrombosis and vessel occlusion.
Absolutely, Crash. And that thrombosis can lead to dire consequences depending on where it occurs. In coronary arteries, it can cause acute myocardial infarction. In cerebral arteries, it can lead to stroke.
Correct. Another complication is peripheral artery disease, where atherosclerosis in the arteries supplying the limbs leads to reduced blood flow. This can cause intermittent claudication or, in severe cases, critical limb ischemia.
Now, Crash, let's talk about how we diagnose atherosclerosis. It's not always easy, given that it develops silently over years.
You're right, Pete. Often the first sign of atherosclerosis is when it causes symptoms of the end organ it's affecting. However, we do have some tools for earlier detection. Imaging techniques like ultrasound can detect thickening of the arterial walls or the presence of plaques.
And don't forget about coronary calcium scoring using CT scans. This can detect calcification in the coronary arteries, which is a marker of atherosclerosis.
Good point. There are also some biomarkers we can use like high-sensitivity C-reactive protein, HSCRP, which can indicate the presence of vascular inflammation.
Now let's move on to a condition that's closely related to atherosclerosis, coronary artery disease, or CAD. This is where atherosclerosis specifically affects the coronary arteries that supply the heart muscle.
Right, you are, Pete. CAD is a major cause of morbidity and mortality worldwide. The primary etiology, as you mentioned, is atherosclerosis of the coronary arteries. However, it's worth noting that coronary artery spasm can also cause CAD, although this is less common.
Good point, Crash. Now, what about the clinical presentation of CAD? It can manifest in several ways, right?
Absolutely. One of the classic presentations is angina pectoris, chest pain, or discomfort that occurs when the heart muscle doesn't get enough oxygen-rich blood. This can be further classified into stable and unstable angina.
Can you elaborate on the difference between stable and unstable angina, Crash?
Sure thing, Pete. Stable angina is predictable chest pain that occurs with exertion and is relieved by rest or nitroglycerin. It's caused by a fixed atherosclerotic narrowing of the coronary arteries. Unstable angina, on the other hand, is chest pain that occurs at rest or with minimal exertion, or angina that's getting worse over time. It's often caused by a partially obstructing thrombus on a ruptured plaque.
Excellent explanation, crash. And of course, CAD can also manifest as myocardial ischemia, which might be silent or cause symptoms like shortness of breath, fatigue, or nausea.
That's right, Pete. Now let's talk about how we diagnose CAD. What are some of the key diagnostic tools?
Well, one of the primary tools is stress testing. This can be done through exercise stress tests, where the patient exercises on a treadmill while their ECG is monitored. We're looking for Saint segment changes that indicate ischemia.
And for patients who can't exercise, we can use pharmacologic stress tests with drugs like dobutamine or adenosine, right?
Exactly, crash. We also use cardiac biomarkers, particularly when we suspect acute coronary syndrome. Troponin I and T are highly specific for myocardial injury.
Don't forget about coronary angiography, Pete. It's the gold standard for diagnosing CAD, allowing us to visualize the coronary arteries and identify any narrowing or blockages.
Absolutely right, Crash. Now, let's discuss management of CAD. It involves both pharmacologic and potentially surgical interventions.
That's right, Pete. Pharmacologic management often includes antiplatelet agents like aspirin, statins to lower cholesterol, beta blockers to reduce heart rate and blood pressure, and ACE inhibitors to protect the heart.
And for surgical management, we have options like coronary artery bypass grafting and percutaneous coronary intervention, PCI, also known as angioplasty with stent placement.
Exactly. The choice between CABG and PCI depends on various factors, including the number and location of blocked arteries, the patient's overall health, and whether they have other conditions like diabetes.
Great point, Crash. Now, let's move on to a critical complication of CAD, myocardial infarction, or MI. This is where the rubber really meets the road in terms of coronary artery disease.
You got that right, Pete. MI occurs when there's prolonged ischemia leading to irreversible damage and necrosis of the heart muscle. It's often the result of a complete blockage of a coronary artery, typically due to a thrombus forming on a ruptured atherosclerotic plaque.
Exactly. And it's important to note that we classify MI into two main types, ST elevation myocardial infarction, STEMI, and non-street elevation myocardial infarction, NSTEMI. Can you explain the difference, Crash?
Sure thing, Pete. In STEMI, we see street segment elevation on the ECG, indicating full thickness, transmural myocardial damage. This usually results from complete occlusion of a coronary artery. NSTEMI, on the other hand, doesn't show street segment elevation. It's often caused by partial or temporary occlusion and typically results in subendocardial infarction.
Excellent explanation, Crash. Now, let's delve into the pathophysiology of MI. It's a time-dependent process, right?
Absolutely, Pete. The timeline of ischemic injury is crucial. Within seconds to minutes of coronary occlusion, we see decreased contractility and relaxation of the affected myocardium. If reperfusion occurs quickly, this damage can be reversible.
And if the ischemia persists?
If ischemia continues for 20 to 40 minutes, we start to see irreversible damage. The necrosis typically starts in the subendocardium and progresses outward. After about 6 hours, the full thickness of the myocardium may be affected.
That's right, and it's worth noting that even if we achieve reperfusion after this point, we can see reperfusion injury. This paradoxical damage occurs when oxygen-rich blood returns to the tissue, leading to the production of free radicals and exacerbation of the inflammatory response.
Good point, Pete. Now let's talk about the clinical features of MI. What are some of the key symptoms we should be looking out for?
The classic symptom is chest pain, often described as a crushing or squeezing sensation. It may radiate to the left arm, jaw, or back. However, it's important to note that not all MI present with chest pain. Some patients, particularly women, elderly, and those with diabetes, may have atypical presentations.
That's right. Other symptoms can include shortness of breath, nausea, vomiting, sweating, and a sense of impending doom. On physical exam, we might find tachycardia, hypotension, and in some cases a new murmur if there's damage to the papillary muscles.
Excellent, Crash. Now, let's discuss some of the complications of MI. One of the most immediate and life-threatening is arrhythmia. Ventricular fibrillation in particular can occur in the early stages of MI and is a leading cause of sudden cardiac death.
Absolutely, Pete. Another serious complication is heart failure. The damaged myocardium can't contract effectively, leading to reduced cardiac output. This can manifest as pulmonary edema in left-sided failure or peripheral edema in right-sided failure.
And let's not forget about mechanical complications, Crash. Papillary muscle rupture can lead to acute mitral regurgitation, and ventricular wall rupture can cause cardiac tamponade. These are rare but often fatal if not recognized and treated promptly.
Great points, Pete. Now let's talk about management of MI. The key principle here is time is muscle. The faster we can restore blood flow, the more myocardium we can save.
Absolutely. For STEMI, the gold standard treatment is primary percutaneous coronary intervention, PCI, if it can be performed within 90 minutes of first medical contact. If PCI isn't available within this time frame, thrombolytic therapy should be considered.
Right, you are, Pete. And regardless of whether we're dealing with STEMI or NSTE-MI, all patients should receive antiplatelet therapy, usually aspirin plus AP2Y12 inhibitor like clopidogrel, anticoagulation, typically with heparin, and pain control with morphine if needed.
Excellent summary, Crash. Now, for long-term management after MI, we focus on secondary prevention. This includes lifestyle modifications like smoking cessation and dietary changes, as well as medications like statins, beta blockers, and ACE inhibitors.
That's right, Pete. And speaking of lifestyle modifications, did you hear about Marcus Cooper? He's that guy running for president in 2036. Legend has it he once had such severe angina that he couldn't walk up a flight of stairs, but he completely reversed his coronary artery disease through diet and exercise alone. Now he can run a marathon while reciting the entire U.S. Constitution backwards.
Wow, Crash, that's quite a tale. While we can't all be Marcus Cooper, it does highlight the importance of lifestyle changes in managing heart disease. Now let's move on to our next topic, valvular heart diseases.
Absolutely, Pete. Valvular heart diseases are a group of conditions affecting the heart valves. The four main types we need to know for the USMLE, Step 1, are aortic stenosis, mitral regurgitation, mitral stenosis, and aortic regurgitation.
That's right, Crash. Let's start with aortic stenosis. This is a narrowing of the aortic valve opening, which obstructs blood flow from the left ventricle to the aorta. What are some common causes?
Great question, Pete. In older adults, the most common cause is calcific degeneration of a normal trileaflet valve. In younger patients, we might see congenital bicuspid aortic valve or rheumatic heart disease. The key pathophysiology here is increased afterload on the left ventricle, leading to concentric left ventricular hypertrophy.
Excellent explanation, Crash. And what about the clinical presentation?
The classic triad of symptoms in aortic stenosis is angina, syncope, and heart failure. On auscultation, we hear a harsh crescendo-decrescendo systolic murmur, loudest at the right upper sternal border and often radiating to the carotids.
Great. Now let's move on to mitral regurgitation. This is when the mitral valve doesn't close properly, allowing blood to flow back into the left atrium during systole. What are some causes of this condition?
Mitral regurgitation can be caused by various factors, Pete. Acute causes include papillary muscle rupture following MI, infective endocarditis, and chordae tendineae rupture. Chronic causes include mitral valve prolapse, rheumatic heart disease, and left ventricular dilation from any cause.
And what about the hemodynamics of mitral regurgitation, Crash?
In mitral regurgitation, we see volume overload of both the left atrium and left ventricle. This leads to dilation of these chambers over time. The regurgitant volume reduces forward stroke volume, and to compensate, the heart increases total stroke volume.
Excellent. And what would we hear on auscultation?
We'd typically hear a holosystolic murmur, loudest at the apex and radiating to the axilla. In acute severe MR, we might also hear an S3 gallop due to the sudden volume overload of the left ventricle.
Great explanation, Crash. Now let's talk about mitral stenosis. This is a narrowing of the mitral valve opena, obstructing blood flow from the left atrium to the left ventricle. What's the most common cause?
The most common cause worldwide is rheumatic heart disease, Pete. This results from an autoimmune reaction following group A streptococcal infection. The mitral valve becomes thickened and calcified with fusion of the commissures and chordae tendineae.
And what about the hemodynamics and clinical presentation of mitral stenosis?
In mitral stenosis, we see increased pressure in the left atrium, which can lead to left atrial enlargement and eventually pulmonary hypertension. Patients often present with dyspnea, fatigue, and signs of right heart failure as the condition progresses. On auscultation, we typically hear a low-pitched, rumbling diastolic murmur best heard at the apex with the patient in the left lateral decubitus position.
Excellent summary, Crash. Finally, let's discuss aortic regurgitation. This occurs when the aortic valve doesn't close properly, allowing blood to flow back into the left ventricle during diastole. What are some causes?
Aortic regurgitation can be caused by problems with the valve leaflets themselves or dilation of the aortic root. Common causes include bicuspid aortic valve, endocarditis, rheumatic heart disease, and aortic root dilation from hypertension or connective tissue disorders like Marfan syndrome.
And what about the hemodynamics and clinical presentation?
In aortic regurgitation, we see volume overload of the left ventricle, leading to eccentric hypertrophy over time. This results in a widened pulse pressure with a high systolic pressure and low diastolic pressure. On auscultation, we hear an early diastolic decrescendo murmur, best heard at the left sternal border with the patient leaning forward and holding their breath after expiration.
Excellent explanation, Crash. Now, let's talk about how we diagnose these valvular disorders. What's our go-to diagnostic tool?
The gold standard for diagnosing and assessing the severity of valvular heart disease is echocardiography, Pete. It allows us to visualize the valve structure, measure the degree of stenosis or regurgitation, and assess the impact on cardiac chamber size and function.
Absolutely right, Crash. And in some cases, we might use cardiac MRI for further evaluation, especially if the echocardiographic images are suboptimal or if we need to assess for associated aortopathy.
Good point, Pete. Now let's move on to the management of these conditions. In general, the definitive treatment for severe valvular disease is often surgical intervention. Can you elaborate on that?
Certainly, Crash. For severe aortic stenosis or regurgitation, we typically perform aortic valve replacement either surgically or via transcatheter aortic valve replacement, TAVR, in high-risk patients. For mitral valve disease, we might perform mitral valve repair or replacement, depending on the specific pathology and the expertise of the surgical team.
Excellent summary, Pete. And what about medical management?
Medical management is often supportive and aimed at managing symptoms until surgery is indicated. This might include diuretics for volume overload, afterload reduction with ACE inhibitors or ARB in chronic regurgitant lesions, and rate control in mitral stenosis. It's also crucial to provide appropriate endocarditis prophylaxis in high-risk patients.
Great points, Pete. Now let's shift gears and talk about cardiomyopathies. These are a group of diseases that primarily affect the heart muscle. What are the main types we need to know for the USMLE Step 1?
The three main types of cardiomyopathy we need to focus on are hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. Each of these has distinct pathophysiology and clinical presentations.
Absolutely right, Pete. Let's start with hypertrophic cardiomyopathy, HCM. This is characterized by thickening of the heart muscle, particularly the left ventricle. What's the most common cause?
The most common cause of HCM is genetic mutations in sarcomere proteins, CRASH. It's typically inherited in an autosomal dominant pattern. The most commonly affected genes are those encoding beta-myosin heavy chain and myosin-binding protein C.
Excellent. And what about the pathophysiology and clinical presentation of HCM?
In HCM, we see asymmetric septal hypertrophy, which can lead to left ventricular outflow tract obstruction. This obstruction is often dynamic, worsening with conditions that increase contractivity or decrease preload. Patients may present with dyspnea, chest pain, palpitations, or syncope, especially with exertion. HCM is also a leading cause of sudden cardiac death in young athletes.
Great explanation, Pete. Now let's move on to dilated cardiomyopathy, DCM. What's the characteristic feature of this condition?
Dilated cardiomyopathy is characterized by dilation and impaired contraction of one or both ventricles. It can be caused by various factors, including genetic mutations, viral myocarditis, alcohol abuse, and certain medications like doxorubicin.
And what about the clinical presentation of DCM?
Patients with DCM typically present with signs and symptoms of heart failure, crash. This can include dyspnea, fatigue, peripheral edema, and reduced exercise tolerance. They're also at increased risk for arrhythmias and thromboembolic events due to the dilated, poorly contracting ventricles.
Excellent summary, Pete. Finally, let's discuss restrictive cardiomyopathy. What's the key feature of this condition?
Restrictive cardiomyopathy is characterized by normal or decreased volume of both ventricles with impaired ventricular filling. This can be caused by infiltrative diseases like amyloidosis or sarcoidosis, endomyocardial fibrosis, or radiation-induced fibrosis.
Great. And how does this typically present clinically?
Patients with restrictive cardiomyopathy often present with signs and symptoms of right heart failure, including peripheral edema, hepatomegaly, and ascites. They may also have dyspnea and fatigue. A key feature is that the symptoms of right heart failure often predominate over left heart failure symptoms.
Excellent explanation, Pete. Now let's talk about how we diagnose these cardiomyopathies. What's our primary diagnostic tool?
Echocardiography is our go-to initial diagnostic test for cardiomyopathies, crash. It allows us to assess ventricular size, wall thickness, and systolic and diastolic function. In HCM, we might see asymmetric septal hypertrophy and systolic anterior motion of the mitral valve. In DCM, we'd see dilated ventricles with reduced ejection fraction. And in restrictive cardiomyopathy, we'd see normal or small ventricles with preserved systolic function but impaired diastolic filling.
Great summary, Pete. And what about other diagnostic methods?
Certainly, crash. Cardiac MRI can provide additional information, especially in cases where the echocardiographic images are suboptimal. It's particularly useful in HCM for assessing the degree and distribution of hypertrophy, and in restrictive cardiomyopathy for identifying infiltrative diseases like amyloidosis. Genetic testing can also be valuable, especially in HCM and some forms of DCM.
Excellent points, Pete. Now let's discuss the management of these conditions. What are some key strategies?
Management strategies vary depending on the type of cardiomyopathy and the specific symptoms, crash. In HCM, we often use beta blockers or calcium channel blockers to reduce contractility and improve diastolic filling. We also consider implantable cardioverter defibrillators, ICDs, in high-risk patients to prevent sudden cardiac death.
And what about for DCM?
For DCM, management is similar to that of heart failure with reduced ejection fraction. This typically includes ACE inhibitors or ARBs, beta blockers, and aldosterone antagonists. Diuretics are used for symptom relief in volume-overloaded patients. In advanced cases, we might consider cardiac resynchronization therapy or even heart transplantation.
Great summary, Pete. And for restrictive cardiomyopathy?
Management of restrictive cardiomyopathy is often challenging, crash. We focus on symptom management with diuretics and try to maintain sinus rhythm, as these patients often don't tolerate atrial fibrillation well. If there's an underlying cause like amyloidosis, we would also target that. In advanced cases, heart transplantation might be considered.
Excellent overview, Pete. Now let's wrap up our discussion with a few USMLE-style questions to test our understanding. Here's the first one. A 55-year-old man presents with progressive dyspnea and peripheral edema. Echocardiogram shows dilated left and right ventricles with an ejection fraction of 25%. Which of the following is the most likely diagnosis?
Based on the presentation and echocardiogram findings, the most likely diagnosis is dilated cardiomyopathy. The dilated ventricles and reduced ejection fraction are characteristic of this condition.
Correct, Pete. Here's another one. A 22-year-old college basketball player collapses during a game and is successfully resuscitated. His family history is significant for sudden cardiac death in his brother at age 25. Which of the following is the most likely diagnosis?
Given the young age, the context of collapse during exercise, and the family history of sudden cardiac death, the most likely diagnosis here is hypertrophic cardiomyopathy. HCM is a leading cause of sudden cardiac death in young athletes and often has a genetic component.
Excellent reasoning, Pete. Let's do one more. A 65-year-old woman presents with dyspnea and peripheral edema. Echocardiogram shows normal left ventricular size and systolic function, but impaired diastolic filling. Cardiac MRI shows diffuse late gadolinium enhancement. Which of the following is the most likely diagnosis?
Based on the presentation of heart failure symptoms, normal ventricular size and systolic function, but impaired diastolic filling, and the MRI findings, the most likely diagnosis is restrictive cardiomyopathy, possibly due to cardiac amyloidosis. The diffuse late gadolinium enhancement on cardiac MRI is characteristic of amyloid infiltration.
Great job, Pete. You've really demonstrated a solid understanding of these cardiomyopathies. Remember, folks, understanding the pathophysiology and clinical presentations of these conditions is crucial for the USMLE Step 1.
Absolutely, Crash. And don't forget to review the diagnostic criteria and management strategies for each type of cardiomyopathy. These topics are high yield for the exam.
You're absolutely right, Pete. Now let's move on to our final topic for today, congenital heart defects. These are structural problems with the heart that are present at birth. They can range from simple defects with minimal clinical significance to complex abnormalities requiring immediate intervention.
That's right, Crash. For the USMLE Step 1, it's important to understand the basic pathophysiology, clinical presentation, and management of the most common congenital heart defects. Let's start by dividing them into two main categories, acyanotic and cyanotic defects.
Good idea, Pete. Let's begin with acyanotic defects. These are defects that don't typically cause cyanosis in infancy because there's no significant right-to-left shunting of deoxygenated blood. What are some common examples?
The most common acyanotic defects we need to know are atrial septal defect, ASD, ventricular septal defect, VSD, and patent ductus arteriosus, PDA. These all involve left-to-right shunting of blood. Let's start with ASD. Can you describe the pathophysiology, Crash?
Sure thing, Pete. In an ASD, there's an abnormal opening in the septum between the atria. This allows oxygenated blood from the left atrium to shunt into the right atrium, increasing right heart blood flow. Over time, this can lead to right atrial and ventricular dilation and pulmonary hypertension if left untreated.
Excellent explanation, Crash. And what about the clinical presentation?
ASDs are often asymptomatic in childhood. When symptoms do occur, they might include easy fatigability, recurrent respiratory infections, and palpitations. On auscultation, we typically hear a fixed split S2 and a systolic ejection murmur at the upper left sternal border due to increased flow across the pulmonary valve.
Great summary, Crash. Now let's move on to ventricular septal defect, VSD. How does this differ from ASD?
In a VSD, the defect is in the septum between the ventricles. This allows oxygenated blood to shunt from the left ventricle to the right ventricle during systole. The amount of shunting depends on the size of the defect and the pressure difference between the ventricles.
And what about the clinical presentation of VSD?
Small VSDs might be asymptomatic or cause a loud holosystolic murmur. Larger VSDs can lead to symptoms of heart failure in infancy, including poor feeding, failure to thrive, and tachypnea. On auscultation, we typically hear a harsh holosystolic murmur best heard at the left lower sternal border.
Excellent, Crash. Now let's discuss patent ductus arteriosus, PDA. What's the underlying issue here?
In PDA, the ductus arteriosus, which normally closes shortly after birth, remains open. This allows blood to flow from the aorta to the pulmonary artery, increasing pulmonary blood flow. The classic murmur of PDA is described as machinery-like and is continuous throughout systole and diastole.
Great explanation, Crash. Now let's move on to cyanotic defects. These are defects that typically cause cyanosis in infancy due to right-to-left shunting of deoxygenated blood. What are some key examples we need to know for the USMLE Step 1?
The two most important cyanotic defects to understand are tetralogy of Fallot, TOF, and transposition of the great vessels, TGV. Let's start with TOF. Can you break down the four components of this defect, Pete?
Certainly, Crash. Tetralogy of Fallot consists of four key components. 1. Ventricular septal defect. 2. Right ventricular outflow tract obstruction, pulmonary stenosis. 3. Overriding aorta. And 4. Right ventricular hypertrophy. The degree of cyanosis depends on the severity of the pulmonary stenosis and the amount of right-to-left shunting across the VSD.
Excellent breakdown, Pete. And what about the clinical presentation of TOF?
Infants with TOF typically present with cyanosis that worsens with crying or feeding. They may also have TET spells minus episodes of severe cyanosis and hypoxia, often triggered by agitation. On auscultation, we hear a harsh systolic murmur along the left sternal border due to the pulmonary stenosis.
Great summary, Pete. Now let's discuss transposition of the great vessels, TGV. What's the fundamental issue in this defect?
In TGV, the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. This creates two parallel circulations. The oxygenated blood recirculates to the body, and oxygenated blood recirculates to the lungs. Survival depends on mixing of blood between these two circulations, often through an ASD, VSD, or PDA.
Excellent explanation, Pete. And how does TGV typically present?
TGV usually presents with severe cyanosis within the first few hours or days of life. Without adequate mixing, hypoxemia can rapidly progress to metabolic acidosis and shock. Interestingly, the chest X-ray often shows a characteristic egg-on-string appearance due to the narrow mediastinum and enlarged heart.
Great point about the chest X-ray, Pete. Now, let's talk about the management of these congenital heart defects. What are some key principles?
Management depends on the specific defect and its severity, Crash. For acenotic defects, small ASDs and VSDs may close spontaneously and can be monitored. Larger defects often require surgical closure. PDAs can sometimes be closed with indomethacin in premature infants, or they may require surgical or catheter-based closure.
And what about for cyanotic defects like TOF and TGV?
Cyanotic defects usually require surgical intervention. For TOF, complete surgical repair is typically performed in infancy. In some cases, a temporary palliative shunt might be placed first to increase pulmonary blood flow. For TGV, an arterial switch operation is usually performed in the neonatal period. Before surgery, prostaglandin E1 is often used to keep the ductus arteriosus open and allow for blood mixing.
Excellent summary, Pete. It's crucial for USMLE Step 1 students to understand these management principles. Now let's wrap up with a few more practice questions. Here's one. A newborn presents with cyanosis that worsens with crying. Physical exam reveals a harsh systolic murmur along the left sternal border. Which of the following is the most likely diagnosis?
Based on the presentation of cyanosis worsening with crying and the harsh systolic murmur, the most likely diagnosis is tetralogy of Fallot. The cyanosis worsening with crying is characteristic of TET spells, and the murmur is consistent with the pulmonary stenosis component of TOF.
Excellent reasoning, Pete. Here's another. A 25-year-old woman presents with fatigue and palpitations. On auscultation, there's a fixed split S2 and a systolic ejection murmur at the upper left sternal border. Which of the following is the most likely diagnosis?
Given the patient's age, symptoms, and especially the fixed split S2, the most likely diagnosis is an atrial septal defect, ASD. The fixed split S2 is characteristic of ASD, and the systolic ejection murmur is due to increased flow across the pulmonary valve.
Great job, Pete. One last question. A premature infant is found to have a continuous machinery-like murmur on auscultation. Which of the following is the most appropriate initial management?
The machinery-like murmur is classic for a patent ductus arteriosus, PDA. In a premature infant, the most appropriate initial management would be indomethacin administration. Indomethacin can help close the PDA in many premature infants, potentially avoiding the need for surgical intervention.
Excellent answer, Pete. You've really demonstrated a solid grasp of these congenital heart defects. Remember, folks, understanding the pathophysiology, clinical presentations, and management of these conditions is crucial for the USMLE Step 1.
Absolutely, Crash. And don't forget to review the associated embryology and the specific genetic syndromes that can be associated with some of these defects, those are also high-yield topics for the exam.
Great point, Pete. Well, that wraps up our comprehensive review of cardiovascular pathology for the USMLE Step 1. We've covered a lot of ground today, from atherosclerosis and coronary artery disease to valvular disorders, cardiomyopathies, and congenital heart defects.
We sure have, Crash. It's been quite the journey through the heart and blood vessels. I hope our listeners feel more confident in their understanding of these crucial topics. Remember, cardiovascular pathology is a high-yield area for the USMLE Step 1, so make sure to review these concepts regularly.
Absolutely, Pete. And speaking of regular review, did you know that our buddy Marcus Cooper once memorized an entire cardiology textbook in just 24 hours? He said it was like his brain was a sponge, soaking up every detail about the cardiovascular system. Now that's some serious study dedication.
Wow, Crash, that's quite a feat. While we can't all be Marcus Cooper, we can certainly take inspiration from his dedication. To our listeners, remember that consistent, focused study is key. Break these topics down into manageable chunks, use mnemonics and visual aids, and don't hesitate to reach out if you need help understanding a concept.
Couldn't agree more, Pete. Well, that's all the time we have for today's Uber School production. Thanks for joining us on this deep dive into cardiovascular pathology. Keep those hearts pumping and those synapses firing.
And remember, future doctors, in the words of William Osler, the good physician treats the disease. The great physician treats the patient who has the disease. Keep studying, stay curious, and we'll see you next time on Uber School's USMLE Step 1 Review.